Now we will learn Brown Sequard syndrome. Brown Sequard syndrome or hemisection of spinal cord. Hemisection of spinal cord. This is our spinal cord. This is central canal. This is the posterior horn. This is anterior horn. This is posterior column. And this is the lateral posterior funiculus, lateral funiculus, and the anterior funiculus. This is anteromedian fissure. This is the section of a spinal cord. Okay. Now, if hemisection, this much is affected by the loss of blood supply, and why this result? Because due to the stab injury or gunshot or myelitis, anyhow the half of the is affected, then it is called Brown Sequard syndrome. But it is not so that it is it can be partial and it is complete, that the complete half of the spinal cord will be affected, and it is very rare the partial, the few parts like anteriorly or laterally, posteriorly, somehow it is affected, then it is called the partial Brown Sequard syndrome. Okay, now what will happen if this will compromised? Then this is the dorsal column, this is tract of gall, and this is tract of Burdak. Here is the site of posterior or dorsal spinocerebellar. This is the ventral spinocerebellar. This is the site of corticospinal tract, this descending tract, and this is the lateral spinothalamic, and here is the site of anterior spinothalamic tract, and here is the hypothalamospinal tract. This all will get compromised. So what will happen? First, look at the dorsal column sensation. Dorsal column, that is the posterior funiculus. What will happen? So this is the cerebral hemisphere. This is the midbrain, this is pons, this is medulla oblongata, and this is the spinal cord. This is the one section of the spinal cord. This is another section. This is from the lower limb, this is from the upper limb. Now this is dorsal root ganglia. This is the dorsal root, and this is ventral root. Both unite to form the spinal nerve. This is dorsal rami, this is ventral rami. The first order neuron enter. This is the dorsal root ganglia. The cell body of first order neuron lies here. Now it comes into the posterior horn. Then without synapsin, it goes medial along the posterior median septum. Now it ascend, and at the upper level of medulla oblongata, it synapse in the, this is the nucleus gracilis. Okay, and this tract is called the tract of gall or fasciculus gracilis. Okay, now the second order neuron is start and form the internal arcuate fiber and goes to opposite side. This is the great sensory decussation, and this, now after that it is called medial lemniscal system. Now it goes to the, where is our thalamus, so it goes to the ventral posterior lateral nucleus of the thalamus. From there, through the posterior limb of the internal capsule, the second order neuron starts from the nucleus gracilis and ends at interposterior lateral nucleus of the thalamus. Then from posterior limb of the internal capsule, it ends at the sensory area, that is the postcentral gyrus. Okay, now what happen if hemisection will be there? Suppose the affected area is this. So there is no crossing occur at the spinal level. We have to very much focus on the crossing over the spinal level. what we are saying, there is no crossing of at the spinal level. So at the site of lesion, at the site of lesion of spinal cord, there will be complete, the all sensation which are entering through this path only, through the dorsal root ganglia, this is affected of that side. So the complete loss of anesthesia, because all are upgoing fiber, so sensory fiber, complete loss of sensation, not anesthesia, complete loss of sensation of which type? Tract of Gall is for which type? The fine motor, fine touch, vibration, position sense, joints position and joint sensation, then conscious proprioception, 2-point discrimination, astereognosis. All these are the dorsal column sensation, and the complete loss of this sensation at the site of the lesion. And below that there is ipsilateral loss of this sensation. At this side there is complete loss, because all the sensation are carrying by this path only, the dorsal root ganglia. So complete loss, we have to write complete loss of sensation of all type at the site of lesion, and below that ipsilateral loss of dorsal column sensation. These are all dorsal column sensation. Okay, this is about the tract of Gall, which is taking the these dorsal column sensation from the lower limb, and from the upper limb, this is for the upper limb. This is added laterally, the cerebellar primary order neuron, without synapse. It goes up to the, here is the nucleus cuneatus. This is our nucleus cuneatus. This fasciculus is called fasciculus cuneatus or tract of Burdak. Then it forms internal arcuate fiber, and then medial lemniscal system. It crosses to opposite side in the upper part of the medulla oblongata, forming the great sensory decussation, and ends at ventroposterolateral nucleus of the thalamus. And from there, third order neuron, after through the posterior limb of internal capsule, ends at sensory area, that is the postcentral gyrus. Okay, so at that side on the complete loss, and the also in the upper limb there is, if it depends where happens, if tract of there is it carries tract of Burdak or cuneatus, it carries the dorsal column sensation from the upper limb and the upper half of the trunk, and this is from the lower limb and the lower half of the trunk. Okay, so this is dorsal column sensation. Now coming to the what happens to the other tracts if Brown-Sequard syndrome occur. This is our midbrain, this is pons medulla oblongata, this is a spinal cord. Okay, now we are making the lateral and anterior spinothalamic tract. Okay, this is a spinal cord sections at different level. This is central canal. This is dorsal root ganglia. And this is our spinal nerve. This is ventral and the dorsal rami. The first order neuron, the cell body lies in the dorsal root ganglia. Now it ends at substantia gelatinosa in the posterior horn. Then it crosses to opposite side. If crosses to opposite side in the lateral side, lateral funiculus, crosses to opposite side in the lateral funiculus, then it is lateral spinothalamic tract. And if this crosses to the anterior, then it is anterior spinothalamic tract. Okay, there you can say this, not this is the same pathway. This I am making lateral spinothalamic tract. so just to cut it, and then it goes laterally and then it ascend up. One thing I mentioned already mentioned in earlier video, that it crosses in taking oblique path. So 1 to 2 segment above, it is going to the opposite side, and now it ascend in the lateral funiculus and then going to the BPL nucleus of the thalamus, where the second order neuron ends, then third order neuron through the posterior limb of the internal capsule going to the postcentral gyrus. Okay, this is the pathway. And if the lesion occur, then suppose this side lesion occur, then the opposite side, first at the level of lesion, there is a complete loss of sensation. And second thing is contralateral side of loss of sensation of pain and temperature, which is carried by the lateral spinothalamic tract, but 2 segment below. Okay, because it is taking an oblique course. If while they ascend, they take oblique course. So 2 segment below. Now coming to the anterior spinothalamic tract, it carries the crude touch and pressure sensation. The cell body lies in the dorsal root ganglia. Now it enters and ends at substantia gelatinosa, second order neuron it starts, and coming to the anterior spinothalamic tract, then it ascend and ends at second order neuron, ends at the BPL nucleus of the thalamus, and then third order neuron via the posterior limb of the internal capsule ends at postcentral gyrus. And it goes along with the upper part of the spinal cord. It along with the spinotectal tract, it forms the spinal lemniscus. Okay, this anterior spinothalamic tract carries the crude touch and pressure. So at the site of lesion for anterior spinothalamic tract, at the site of lesion there is complete loss of sensation. And second thing is the here also spinal level crossing occur. So contralateral side loss of crude touch and pressure sensation 4 to 5 segment below, because it is taking an oblique course while ascends, but it takes 4 to 5 segment to cross. Lateral spinothalamic 1 to 2 segment, and anterior spinothalamic 4 to 5 segment. So 4 to 5 segment below there is loss of anterior spinothalamic tract sensation, that is the crude touch and pressure. Now coming to the spinocerebellar tract. Okay, this is our cerebral hemisphere, this is midbrain, pons, medulla oblongata. This is our spinal cord, medulla oblongata, pons. This is our cerebellum. This is inferior cerebellar peduncle, medial cerebellar peduncle. This is superior cerebellar peduncle. Here is the superior, middle, and the inferior cerebellar peduncle. This is the both are from the ventral and the dorsal. Both are taking the sensation, that is the unconscious proprioception from the lower limb. But the dorsal column, it takes the fine motor proprioceptive sensation, whereas the ventral gross motor proprioceptive sensation from the lower limb as well. Both are for the lower limb. And from the upper limb, it is the cuneo-cerebellar tract. Okay, now what we have to make, this is the spinal cord section. The first order neuron lies in the dorsal root ganglia. Now it is coming to the, it ends at nucleus proprius, and then here is the dorsal spinocerebellar. Now it goes to the same side, and now it ascend. This is the second order neuron. It ascend, and through the inferior cerebellar peduncle, it ends at cerebellum. So it is only 2 order 2 order neurons are there. All other are 3 order neuron to complete the tract, but here is the only two neurons. First neuron in that nucleus class called nucleus proprius, or Clark nucleus, or nucleus dorsalis. Okay, nucleus dorsalis or class column. Now and it is going to the same side, to the cerebellum. So if the lesion occur, because a spinal level crossing do not occur, so at the site of lesion there is, first we have to write complete loss of sensation. Second, we have to write there is ipsilateral lower limb dystaxia. Okay, lower limb dystaxia. Now coming to the ventral spinocerebellar, it is coming. Here is the first order neuron. Cell body lies in the dorsal root ganglia. Now it ends at nucleus dorsalis, but it is the central canal. It is going to the opposite side. This is the site of anterior spinocerebellar. It is going to the opposite side. Now it ascend up to the superior cerebellar peduncle, midbrain, and through the superior cerebellar peduncle it is going to the cerebellum, and within the substance of the cerebellum, it is coming to the opposite side. Okay, so finally it is coming to the opposite side, but spinal level crossing occur. We have to focus on spinal level crossing when we are dealing with the Brown-Sequard syndrome, which is the hemisection of a spinal cord. We have to focus on spinal level crossing. So even though it ends at the same side cerebellum, but a spinal crossing occur here and spinal level crossing do not occur here. So what will be the result at the level of the lesion? First we have to write complete loss of sensation, and second we have to write there is contralateral lower limb dystaxia. Okay, here this is for what? The spinocerebellar tract is for unconscious proprioception, but this is also proprioception which is we are not aware of, and this dorsal column is for we are aware of conscious proprioception, but both have proprioceptive sensation. So in that case there is dorsal spinocerebellar as well as the dorsal column sensation. Both are taking from the ipsilateral side. So ipsilateral dystaxia will be more compared to the contralateral, because contralateral one is taken by the ventral spinocerebellar tract. Okay, now coming to the motor. Now this is our cerebral hemisphere. This is midbrain pons, medulla oblongata, midbrain pons, medulla oblongata. This is a spinal cord, and here is the spinal cord sections. Now it starts here, the cell body lies, first order neuron. It starts from the precentral gyrus, which is the motor area. Now through the internal capsule it is coming, and now in the lower part of the medulla oblongata it crosses to opposite side and forms the lateral corticospinal tract. If do not cross, then it forms the anterior corticospinal tract, and this, if it crosses, then it forms the lateral corticospinal tract. It contains 90% fiber of this pyramidal tract. This is also known as pyramidal tract, and it contains only 10% fiber. This is for the motor activity for the peripheral muscle, that is for the limbs, and this is for the axial musculature. Okay, so it crosses and form the great motor decussation. Now it descend, and this is the it descend in the, here is the site of the lateral corticospinal tract. Here it ends at is coming at this site, and through the interneuron. Now it's at alpha motor neuron. alpha motor neuron. One thing I have mentioned that it is not ending at the alpha motor neuron, it ends at interneuron, and in this interneuron acts on both alpha motor neuron and the gamma motor neuron. Gamma motor neuron works for the intrafusal fiber, whereas the alpha motor neuron works for the extrafusal fiber, and through this it runs through the anterior spinal, the anterior nerve root, and going to the periphery for its action. Here it ends in the, you can say, alpha motor neuron or interneuron. Okay, so this is first order neuron is coming up to here, and now second order neuron starts from here and going to the periphery. Now what happens? There is a spinal level crossing do not occur. The lateral corticospinal level, corticospinal tract. So what we at the site of lesion, not complete anesthesia. This is the motor tract. So at the site of lesion there is lower motor neuron type of lesion, and below the level of lesion there will be upper motor neuron. Upper motor neuron is this which is carrying from the direct from the cerebral hemisphere, and it puts an inhibitory influence over दिस न्यूरॉन. ये उस तरीका है जैसे अगर डैड का डेथ हो जाता है तो ये इनिबिटरी सिग्नल्स देता है जो सन को कंट्रोल रखता है. ये सब, ये लोअर मोटर जो यहाँ पे अल्फा न्यूरॉन्स हैं यहाँ पे एंटीरियर हॉर्न सेल में, दीज आर सन, और ये ऊपर से जो ट्रैक्ट आ रहा है दीज आर द इनिबिटरी इन्फ्लुएंस, ये कंट्रोल करके रखता है. तो ये जब लीजन हो जाता है तो पापा का इनिबिटरी इन्फ्लुएंस कम हो जाता है, ख़त्म हो जाता है. कम क्या हो जाएगा, ख़त्म हो जाता है. तो पहले तो ये स्पाइनल शॉक में हो जाता है पापा के मरने पे, उसके बाद ये इनका एक्टिविटी बढ़ जाता है. देयर विल बी मोर इम्पल्स डिस्चार्ज जस्ट लाइक आफ्टर द डेथ ऑफ फादर. फर्स्ट इन द स्पाइनल शॉक एंड देन नाउ this is upper motor neuron and at the site of lesion lower motor neuron. So what is the feature of the lower motor neuron is again MTP, that is the loss of muscle mass, there is loss of tone, there is loss of power, there is areflexia, there is fasciculation. Okay, so at the site of lesion lower motor neuron lesion, that is the loss of muscle mass, loss of tone, loss of power, MTP, fasciculation, areflexia. Okay, and below the site of lesion there will be upper motor neuron type, because these have lost the upper motor neuron control. Okay, so upper motor syndrome will occur, and there will be also the muscle mass is maintained but slight loss of muscle mass. Okay, and the loss of power, also there is paralysis but increase in tone, because there will be more impulse discharge from the anti-horn cell. So there will be rigidity, there is, you can say, spasticity, and which type of increased tone is known as spasticity, but also hypertonia. Okay, and which type of spasticity will be there? There is clasp knife type, rigidity or spasticity. Okay, in which there is resistance. In a type of knife there is first resistance, and then it again suddenly it loses the resistance and opens up. That type of rigidity is found in the joint. Okay, so clasp knife. And one is the lead pipe type, which is very much characteristic of Parkinsonism. And there is hyperreflexia, Babinski upgoing. Okay, so these are the feature of upper motor neuron. And when at this site lesion, the anterior spinocerebellar, as it do not cross to the opposite side coming, and then at the spinal level it crosses. It also crosses, this is the site of the anterior spinocerebellar, and it also crosses, but the spinal level crossing occur. So there will be if the lesion in this side, as it going to the opposite side, it will escape. But opposite side come here at this level, so there will be axial musculature of contralateral side, but there will be contralateral, in axial muscle only runs in the middle. So axial musculature, we are dealing with the hemisection, so axial musculature will not be affected because it is carried by the opposite side. And because spinal level crossing occur, so antecorticospinal tract, we should write that there is opposite side paralysis of opposite side loss of antecorticospinal tract, but this is not divided into the ipsilateral or contralateral. It is carrying the sensation for the axial musculature which runs in the middle, so there is no question of ipsilateral or contralateral. So at that level, axial musculature, there will be lower motor neuron, because the spinal crossing occur at that level only. So this is all about and also the hypothalamospinal tract. Hypothalamospinal tract, suppose it starts from the hypothalamus and it is carrying the sympathetic sensation and coming up to the T1 T2 level, then it outflows and up to the T1 and T2 and up to the L2. And if at T1 level there is cell nucleus of Budge, nucleus of Budge is there in the intermediolateral nucleus, and then it ascends up to the superior cervical ganglion. This is the preganglionic sympathetic. Now postganglionic sympathetic starts and going to the orbit through the superior orbital fissure. So there will be, as it do not cross, so and if the lesion occur at the level of T1 and T2, then ipsilateral Horner syndrome will occur. And in Horner syndrome there is PAMAL, that is the ptosis, meiosis and hydrosis and ophthalmosis and the loss of ciliospinal reflex. So this is all about the Brown-Sequard syndrome. Thank you.